Welcome to the session, Providing Psychological Services in the Face of Uncertainty, a question and answer series. I'm Dr. Jennifer Todd from the Office of Continuing Education in Psychology at the American Psychological Association. It is my pleasure to be moderating today's session. We are providing these sessions in recognition of the challenges that face us today and in the days ahead. Those challenges take many forms, and so do our responses. Today's webinar is the second in a series of 3 question and answer webinars designed to help practitioners maintain continuity of care in relation to the clients they serve. Like many of us, many of those clients are grieving the loss of normalcy and often more. Employment, personal health, and family welfare also take their place alongside a range of other challenges and losses. Our presenters today are Dr. Jeff Zimmerman and Dr. Jared Skillings. Dr. Zimmerman has been in independent practice since 1981. He is a founder of the Practice Institute, co-author or co-editor of 4 books on practice, and editor of the APA journal, Practice Innovations. Dr. Zimmerman is a frequent presenter and consultant helping mental health professionals build ethically responsible, thriving practices. He was the 2017 president of the Society for the Advancement of Psychotherapy. Dr. Jared Skillings is the Chief Practice Officer in the Practice Directorate at APA. Prior to joining APA, he served as Chief of Psychology at Spectrum Health System in Grand Rapids, Michigan. He has also served as Chair of the APA Board of Professional Affairs and President of the Michigan Psychological Association and the American Academy of Clinical Health Psychology. Prior to this webinar, we requested that questions be submitted to us by email in order to enable Dr. Zimmerman and Dr. Skillings to address as many of your questions as possible during this short 1-hour session. There is also a question box on the GoToMeeting platform. Please submit any additional questions based on the presentation. We will be holding 1 additional Q&A session next Friday. In recognition that we may not be able to address all of the questions in our limited time today. A link to this session recorded last week can be found on the APA website as well, should you want to review from last week. One quick housekeeping note, please be aware that should our GoToMeeting platform go down at any time during today's webinar, we ask that you please wait 15 minutes and try to re-enter the webinar using the same link you used to gain access today. If you're not able to reestablish the webinar because of the ongoing stress to internet systems, we will post the webinar recording and it will be available to you on our website. With that, let me thank Dr. Zimmerman and Dr. Skillings in advance for being here and turn directly to our questions. So the first question I have is for Dr. Zimmerman. We got lots of questions that range across the spectrum. So our first question for Dr. Zimmerman, do you have any guidance for whether to allow clients to continue to choose to come on site if permitted by the city or state? And if so, do you have any recommendations for documenting the client's decision to attend on site and decline the option for teletherapy? Some decline telehealth because they don't have privacy in their homes.
So thank you. I'm glad to be here, and thank you to all of our listeners for signing in today and attending this webinar. My recommendation is to not, my very strong recommendation is to not see clients in your office at this point. A colleague of ours from Spain was so kind enough last week to call in and explain, because they're ahead of us in their experience, explain to me, what has been going on in Spain and how devastating this illness is as it takes hold. I'm looking at a database right now, and Spain has over 100,000 total cases. We have over 250,000 total cases as of today, and the world has over 1 million cases. So we're about 25% of the world, and I don't think we've stopped growing by any means. At this point, we had 15,000 new cases in the last 24 hours, according to this database. This is extremely contagious. I'm not giving medical advice, but from everything we hear, extremely contagious. And what's happening in other countries is the impact of this is devastating, where people are dying alone and all kinds of terrible things are happening. Many of us are now starting to know at least one or more people who have succumbed to the illness and have passed away. I think we have a responsibility to mitigate our risk and a responsibility to mitigate the client's risk and the risk of the client's family and friends. So I would say we should not, even if you are deemed essential personnel, I would still say we should not do it in person. There are issues about telehealth versus audio only, which we may get into if we have time during this hour. I would not want to withhold care, but I think there are a lot of ways to at least connect with our clients besides seeing them in person.
Thank you very much. I think that's important for us to consider in many different aspects of our life. Dr. Zimmerman, during this time of crisis, how do we take care of ourselves in order that we can best then help others? And also, adding to that, what signs should we watch for in others, such as our colleagues, our professional colleagues, that they may not realize that they are in distress?
So I think firstly, we need to recognize that in this crisis, we are both the caregiver and the person that's impacted at the same time. We are in both of those roles. And in order to be at our best as the caregiver, we have to take care of ourselves by seeking support, by using distraction, sometimes by saying no to certain requests, by getting information on the one hand, and also turning off the media at other times when we're feeling like we're about to get overloaded. I think it's important also to use positive reinforcement and positive activities where we feel connected and maybe even a little joyful in the small circles of space that we're now operating in. Some of our colleagues may appear short-tempered, they may appear withdrawn, they may appear panicked, they may be far less compassionate than they usually are. They may be speaking about increased alcohol use or other interpersonal shifts in their behavior, and those all may be indications that they're in more distress. One thing we can, of course, do is reach out to our colleagues. We don't have to wait for them to be in distress. I've had colleagues reach out to me, and I've reached out to some as well, to say, hey, how's it going? Just thought I'd check in with you. It's one of the strategies that even the Red Cross uses on their disaster sites, where people go up to somebody and just say, hi, you want some water? How are you? And it's just that reaching out and that making the connection that can be so helpful. By the way, APA on their website has a self-care advice for healthcare providers during COVID-19, written by Dr. Coons and Berkowitz and Davis, and Drs. Coons, Berkowitz, and Davis, and you may find that helpful. It's dated March 26th, so it's very recent, and it's something you can check into.
Great, thank you very much for that really invaluable advice for all of us. Dr. Skillings, if I could ask you this question that we received. We got a lot of questions about, making this very precipitous shift from routine to having to adjust to telehealth. and a lot of people are struggling to get up to speed in that. So how does one bill? Oh, sorry. Okay. How does one bill for video psychotherapy, which must occur due to quarantines, when it is not usually part of my practice? Does it depend on the insurance company? Some companies are more transparent about how to do this. Can you just provide some general guidance?
Yeah, that's a terrific question. Thanks very much, Jennifer. Let me say first how much I appreciate the opportunity to participate with Dr. Zimmerman. I've known him for a few years, and he is just a bastion of knowledge and wisdom about healthcare, and psychology practice. So I'm just really thankful to him for being willing to do this, and glad I can be a partner.
The feeling is mutual.
Glad to. Thank you, sir. I want to add one. Actually, I'm going to go back one second, and I very much appreciate his suggestion about trying to reduce exposure to the community, to yourself and your loved ones. One of parts of my background is I'm a health psychologist, and so in my previous life before APA, I have staffed the emergency department and the ICU and a range of hospital settings. And I know a lot of our integrated care, health psychology, rehab psychology colleagues are doing the same, as well as some folks who work in forensic settings, psychiatric hospitals, prisons. And so they don't have the same kind of luxuries. And so one of the things I would also encourage us to pay attention to as a whole practice community and a health community, and frankly, the human community, is to try to make sure for those folks who are not able to socially, physically distance right now, that we're able to provide support, that we reach out and check on them to see how they're doing, and to see if there's anything we can do to provide additional support beyond what we normally do during this time. Back to the question about insurance. This has become just an entirely new world in, it feels like 3 weeks. It's hard to imagine that so many people would have changed to doing telehealth and video conferencing. I couldn't have hardly imagined a scenario where people would have changed like this, and yet here we are. And so we're all trying to figure out the right thing to do on the fly as quickly as we can do it. So what I wanted folks to hear first is that APA has been really pushing forward with advocacy, and we have a unified advocacy strategy for both the federal government with CMS and Medicare. And that same strategy is consistent with our states. We have been advocating with governors and insurance commissioners at the state level, as well as individual insurance companies, especially the biggest ones in the country. And what I would suggest, I'm not going to get into the weeds about billing right now, other than just offer a bit of compassion or empathy that I can appreciate how difficult it is to shift to an entirely in-person practice to doing video conferencing. Is that we have some significant guidance on our good practice, practice update newsletter. Because we can't show that to you, we can send you the link later. But if you Google APA practice update, you'll be able to find that very quickly. And it has a lot of detailed billing information for how you should bill video conferencing. Last point, and I'll stop, is that we have continually been advocating for phone-only sessions, which we know is really important to folks. So we have a workaround that just came through the other day from CMS, and we're going to be sending that out probably within the hour or the next 2 hours about what that's going to look like. So we're actively fighting for not just video conferencing, but psychological, neuropsychological testing and phone-only sessions too.
Great, thank you very much. Dr. Zimmerman, given the potential anxiety, stress, and just overall unease that our children may be facing, given the sudden upending of routine and the deprivation of secure relationships usually found in school and other places that they might have found, is there any guidance or support for psychologists or school psychologists that work with children, for the children, for their parents, for their siblings or other caregivers during this pandemic?
This pandemic is such a strain on family systems. We, in many cases, have two parents who are now working from home with 1, 2, 3 or more children living in the home full time, and sometimes in very crowded quarters where during the course of a week, there may be very few people when they're not sleeping at home at one time, and on weekends they may go out. And now we've taken that same family system and encapsulated them in the home without much opportunity to go out. And in some communities, they really have to stay in the family residence 24/7 day, now weeks at a time. They may be able to go out for a walk. It depends if they feel that's safe and how dense their neighborhood is. I think what we can do as psychologists and school psychologists is we can work with the parents. We can be supportive to the parents. We can help them build a structure in their homes, even on the weekends, for how the day is going to look. One of the things that helps bind some of the kids in a good way and behaviorally and helps give them a sense of that there's an infrastructure is that schedule, that they know that it's 10:05 and I'm supposed to be having reading right now. And the more that we can help parents build some of that, that can go a long way, as well as using distraction. And parents can also take shifts in their own child care responsibilities. I call it tag team parenting, where we can encourage parents to have some personal time. And we also have, by the way, families where there's only one adult in the house, in the residence. And that can be even more onerous in those cases. So the idea of really making sure there is some personal time is important. We also can reach out if you have a client relationship, either in the school or in a professional practice. There's the ability to reach out to the child and maybe even have multiple appointments that are short, but they're connected. And that can also help the child feel that they are connecting to you as the professional, and also you may be able to give them some coping skills and tools that will be helpful to them between now and your next phone call or next video call.
Great, thank you. As a parent of a 9-year-old, I can tell you that implementing a structure is difficult, but it is, in my experience, it has really been beneficial. So thank you for confirming the work that I've been trying to do. Dr. Skilling.
This is Jared. We have 5 children, and I agree with that. I agree with that wholeheartedly. Structure is really important.
Great, thank you. So yeah, I've just got one. So yeah, 5 times the work, but yeah, so five times the struggle with screens and structure. But thank you for that. Okay, so what is the recommendation for providing psychoeducational evaluations to children age 10 plus or thereabouts, given the fact that we have to observe social distancing and the reality of doing this over telephone or video? Dr. Skilling, do you have any thoughts on that?
Yeah, I do. I'm going to give you a quick answer on this one, partly because the answers to those questions are just emerging. Just 3 days ago, Medicare approved psychological and neuropsychological testing to be so that we could bill and be reimbursed for it, which is a fantastic win. One of the things, of course, that's happened is because we're having to pivot testing to a virtual environment, we really don't have, other than just a few early studies or guidance, we don't have a lot of formal recommendations. So what we're doing is we're actually starting small expert groups to develop that kind of guidance. And so that will be coming out very, very soon. So I want to hesitate to go too far with offering specific examples so far or in detail right now, other than just a couple. Let me give you some very high level thoughts very quickly, which is that to pay attention to, because of the crisis, children and adolescent symptoms or family symptoms might be getting worse. Even caregivers who are providing any reports of symptoms, they're likely more distressed than normal, and so you might have an exaggerated profile all the way around for what kind of symptoms folks or experiences folks might be having these days. I would also encourage you to pay extra attention to the risk for abuse and neglect right now. We actually got some early data that came out of Illinois that the reports of abuse and neglect were down. And the actual likely reason for that is because children and adolescents don't have as much exposure to mandated reporters. So when you do have the opportunity to see a kid, just make sure you keep that in mind and pay extra attention to that as we go forward, and especially pay attention to vulnerable children. This is uniquely challenging to some types of kids who have trouble with a loss of structure, but kiddos who have autism or challenging ADHD and other kinds of conditions. Those are some examples. Again, we're going to have very specific guidance coming very soon, which we'll make sure we send around to everyone.
I can add a little bit.
Yeah, please.
To that as well.
Please.
When you are doing assessments by video, I think it's also important, if you're not following standardization procedures, many of the instruments are not normed to be done on video, and you may be deviating from your usual standardization practices. That should certainly be noted in the report so that you've got that disclaimer and you can speak to what impact that might have on your observations and your conclusions. However, having said that, virtual methods might be very useful when you're interviewing a client or interviewing parents, interviewing collateral sources, or if there are some online instruments that your clients can take. So you may be able to blend the use of the virtual medium with your assessment as well, even if you can't do it all during these next few weeks. But be sure to put those disclaimers in your report so it's very clear what you did, what was off of the usual process, and how that might have affected your results.
Yeah, I agree 100%.
Thank you. So we got a lot of questions about just how to do this, how to make the switch, and follow guidelines and statutes and regulations that are brand new to many of us. Dr. Skillings, are there any state statutes or regulations that a provider new to this area should keep in mind or should find out about before providing telehealth?
What I'd like to do is just highlight both federal and state statutes for just a minute. All of us historically have been held very strongly to HIPAA regulations. And just as a reminder, the purpose of HIPAA, the primary purpose of it, is intended to keep patient information safe. Now, admittedly, it sometimes feels like it can be overbearing, and maybe it is in some circumstances, but the intention of it is really to keep patient information and patient data safe. What's happened is that the federal government, because they knew that so many healthcare providers were moving to telehealth, they have relaxed their requirements for HIPAA. So, for example, the government has overtly said that you can use non-HIPAA compliant telehealth platforms. I realize I'm using HIPAA compliant in this format, and that is not technically accurate. I'm saying it that way to make it easy to understand. So the government has relaxed its standards. Sometimes I think what we forget, however, is that most states have their own standards for protection as well. And some states have waived those or have reduced or made more flexible those requirements, and some have not. So you need to really check with your state psychological association. Perhaps your state board of psychology might have guidance up on their website as a way to also provide a one-stop shop for this information. The attorneys in my office, called the Legal and Regulatory Affairs Office, some of you may have heard of that group. They have actually just finished a 50-state review, which will then provide an update on that information. We're hoping to have that online by Monday or Tuesday of next week at the latest. So those are just a couple of points, and then hopefully a resource soon for people to be able to check.
Great. And if I could just add or ask one quick follow-up. Are you aware of interstate restrictions being waived because of COVID, and practitioners being able to take clients referred from other states?
Yes, that's exactly right. So that not only has there been a relaxing of HIPAA, which is what I'm mostly focused on, but it's also licensing laws. So what some states have done, for example, off the cuff, Maryland, which is of course right near DC where we work, um, Maryland has relaxed their laws, and what that does is that allows psychologists from outside of the state to practice or to see patients in Medicare within the state. That does not mean that all insurance companies will reimburse you for that, however. So you have to be careful about that. If you see a patient with a commercial insurer, you might be able to perfectly legally see the patient, but you may or may not get paid. That is also going to be in this 50-state review that I just mentioned, and so you'll be able to figure out which states you can practice in for telehealth. So, for example, you might be able to work, or I'm sorry, you might be able to live in Ohio and see a patient in Maryland, which is really nice, especially for college kids who have most colleges have shut down around the country. If you have a college kid or somebody else who's been displaced, you could continue to see them. So we're going to, again, have that guidance up very quickly.
Great, thank you. I know that there are lots of people that will be anxious to see that guidance, so thank you. Okay, next question for Dr. Zimmerman. When you're working with clients who are essential workers, how do you counsel them through this anxious time and thinking about keeping their family safe while they still have to go and work versus the anxiety of sacrificing necessary income to take time off of work?
It's a really, really hard balancing act. And my hat and my heart goes out to our essential workers, both on this call and the people around the country and around the world who are doing the incredibly heavy lifting of taking care of the ill and the families of the ill as well. I don't think we can counsel them through the anxiety as if the anxiety is going to go away. I think this is a very anxious time, and it's very appropriate to have anxiety. This is not the same as somebody with OCD or some other anxiety disorder that maybe isn't fully founded on rational, factual threats. And here we do have a very, very real, as I said at the outset, very real, very pronounced, yet invisible threat. If we had 250,000 people in this country impacted by a military attack, we would certainly look at that as very, very real and pronounced, in my opinion. And yet we are having that many people impacted. It's just not with bombs and bullets, it's with the virus. So I think the first things we can do is help normalize the anxiety and let them know that the anxiety that they're feeling is understandable and real. We can help them problem solve as to how to not expose family members. That's a very real and appropriate concern. I know some people who, if they have a basement or a spare room, they go into that spare room, their home, and that can feel good to everybody, but they're also trying not to expose their family members. I think we can help them try to get access to resources. I know that there are some banks that are offering deferments on mortgages. There are some government programs that we've recently been hearing about, even the last couple of days, and that may apply to for some of us as well. And I think one thing we can really do is encourage a lot of self-care and rest. If one thing you like to do is read, this is a time to be sure to don't give up the reading or the playing a musical instrument or reading to your kids at night, even if you're doing it by memory over the phone or a video from the same house or however you're doing it. But to have that connection, that self-care, that rest, if you have a partner at home or elsewhere, connecting with your partner and not just feeling like you're out there alone. And we can help them with that. And again, the more frequent check-ins, like I had mentioned earlier today.
Great, thank you very much. Another critical question, these are all equally critical, but Dr. Zimmerman, if you could address what emergency resources are best to use at this time if you have a client that is in crisis and needs a higher level of care or needs emergency psychiatric evaluation, since really police, ambulance, and emergency rooms are full, and really that's not the best place to send someone right now. Do you have any guidance or thoughts on that?
Sure. I would suggest that before you get into that predicament, that you look locally and find what are the diversion programs that are out there. For those of us that may not work with a population of patients or clients that are usually acute, we may not be as aware of what's in our vicinity in terms of non-emergency room diversion programs. They may be a program that's on wheels, or it may be a program sponsored by a psychiatric or a substance abuse facility. So I think the first thing to do is to research what's in your area. And that, by the way, is true if you're doing, as Dr. Skillings was saying, that telehealth, working with that student in Ohio when you live in Maryland, check out what other resources are in that person's community in case they become more acute. And I think we can also call a program directly rather than use the ER as the gateway or the point of entry. We can call the program directly and say, I have a patient who, is this somebody that you can help? And those programs may be able to give you access far more rapidly, or give the patient access far more rapidly than an emergency room, and perhaps far more safely than an emergency room can right now.
Great, thank you. Dr. Skillings, I have a question that we received about billing and public insurance. So when providing service over the phone, typically those type of phones have limitations, or phone appointments have limitations in time and the type of calls received and made. What considerations or options or guidance can you give to agencies who have a majority of their caseload that are indigent?
That's a really important and a very challenging issue. So I'm going to assume for a minute, although it wasn't quite clear from the question whether or not the patient population who it sounds like might be in deep poverty would have access to Medicaid services or not. Let me answer that question first from that perspective. So if the patient has Medicaid insurance, the truth is, around the country right now, in terms of what kinds of services Medicaid agencies are approving or not, it is really the wild, wild west. If you find out what one state does, you have only discovered what one state does. That does not mean that other states are doing that. And so you will have to check to see what your state is willing to approve or not. So that'd be my first suggestion across the whole country. In terms of telephone-only services, that is, we have just gotten approval. I mentioned very briefly earlier that Medicare has approved some brand new codes that nobody has ever had access to. And again, we're going to be sending out some messages later today to explain those in more detail. The very quick summary of those codes is it will allow not just psychologists, but other healthcare professionals to be able to bill. The weird twist is that because of the workaround that Medicare was trying to do, the language in the codes require the patient to call the psychologist. That's the way it's literally written, is the patient has to call the psychologist with a concern, and then the psychologist can provide an assessment or an intervention. Again, we'll make sure that gets sent out here later today to provide some fuller information. But that is only in Medicare that's approved. We're going to be pushing every state Medicaid agency and all of the commercial payers to also approve not just that sort of phone therapy workaround, but full phone therapy in the future, which will hopefully solve the issues that the person asking the question raised.
Yeah, great, thank you. Dr. Zimmerman, I have a question about providing services to healthcare workers. So regarding emotional first aid and volunteering with healthcare workers, what should we keep in mind about these contacts besides the actual content or information or support that we might be able to offer?
Firstly, not every healthcare worker is the same, of course, and many may have very little experience with the kind of trauma that they are going to be seeing. Even the healthcare workers that work in trauma may be ill prepared, but certainly the ones that don't work in an ER or in another environment where there's trauma may be very ill prepared for what they are seeing. And also ill prepared for helping so many people die alone, which is part of what's happening as well. I've heard of cases where the gloved hand of the healthcare worker is taking a moment with a phone on to try to help somebody else deal with their final moments, and the family member on the other side of the digital connection to try to help. Not something that the healthcare worker has probably done in the past or in the distant past. They may have done it 2 hours ago, but they haven't had experience doing that. As well as the healthcare worker who isn't in a traumatic environment, they may be seeing things that are extremely difficult. They also, as we are volunteers and participants. They were victims of this illness at the same time. Even if they're not sick themselves, they may have friends and family who have been ill, and they're certainly trying to cope with it. So I think we need to offer them support. We need to provide education about possible symptoms, for example, sleep and appetite disorders, depression, crying, the usual symptoms that we might speak of. I don't have to go through all of those here. What to look out for in terms of trauma symptoms, and to give them room and an understanding about what vicarious trauma is and how that can impact them.
Yeah, thank you.
This is Jared.
Yeah,
can I add one more item on that? I think that's very, very helpful. One other thing that I think we need to pay attention to is when you look at the data that's coming back from other countries, when their health system gets overrun, they have been forced for ventilators and other high acuity patients to ration care, and that puts the frontline physicians in a terrible position of having to sort out who are the ones who get care and who are not. Now, mostly the United States has not had that happen here yet, but if our trajectory is similar to other countries, it may. And so I think we need to pay attention to also the moral injury that will likely occur because of having to make those really heart-wrenching kinds of decisions. That brings up not just vicarious trauma, but questions about, I think the term they use is a moral injury. So what's right and what's wrong, and those kind of deep-seated personal questions about life itself that are really tough. So another thing to think about if you're treating or working with physicians or frontline staff right now.
And the ones, to just piggyback on that, Jared, the ones that watched those decisions being made and they felt powerless to do anything about it. They couldn't get that ventilator, and they couldn't get the people who made those decisions to rethink their decisions if they disagreed with them. The powerlessness in this whole pandemic is also very, very pronounced.
That's exactly right.
Yeah, thank you. I'm just going to pause a second and let that just sink in, because these are very heady issues that are going to be with us for the near future, at least. So, Dr. Zimmerman, can you talk about how you go about coaching someone through increasing their tolerance to uncertainty? And how do we do this with individuals who are already living with anxiety, trauma, or otherwise have past or present experience with how the bottom can fall out as they try to prevent catastrophizing?
So my mind just went to somebody who frequently washes their hands because they're afraid of getting ill, and they're afraid of the germs and the contamination. And while that behavior X number of months ago might have been deemed as over the top, now we might say, good for you, keep doing it. So it's not just, there's not a standard that is set, because that standard shifts based on the conditions. I think that we can normalize that feeling the bottom is going to fall out. In fact, I would suggest to you the bottom has fallen out, and that's what we're living with, is the bottom has fallen out. Not only can it, but it has. And my colleague in Spain said to us that what they're experiencing is a phase 2 of the illness, which for some is more deadly, especially if you were sick earlier in phase 1. But the phase 2 of the illness can be even more acute and more deadly than phase 1. So I think we can normalize the idea that the bottom has fallen out, and that we can, and that the anxiety that they're experiencing is not necessarily pathology. I think we have to be careful about our own using our diagnostic abilities to look at, is this anxiety reasonable for the situation that our client or patient is in? And is it understandable given their particular circumstance? I think also, as I was saying on a prior question, we can make more frequent contacts. It doesn't mean we have to have a 45 or 50-minute hour appointment, but we can make more frequent contacts, and maybe even a 10-minute or a 15-minute call in 2 or 3 times a week could be more beneficial than a 45-minute once a week. And now the person feels like they're floating, taking care of Jared's, I think you said 4 or 5 children, for full-time by themselves, and they're trying to do that as opposed to having us, the professional, call and maybe do a checkup call. We're not too used to in outpatient psychotherapy doing check-in calls, as a physician might call a series of patients at 7:30 at night and check in and see how you were doing over the past couple of days. But that could really help also ground our clients better than the 1 time a week call. We also need to be thinking about flexing our hours, because if I call a client at 4 o'clock in the afternoon, that may be the worst time to call them if they have young children at home. I might have to be calling at 8 o'clock at night. I might need to get some type of approval from the client that that's a good time, or others might prefer me to call at 6:30 in the morning, because that's before the day gets going on full steam, and they can connect and have some quiet time for even a short call. So more frequent calls, short calls, and calls outside the usual range of business hours.
Great, thank you. We got a lot of questions, which I've spoken to regarding HIPAA and waivers and consent forms. Dr. Zimmerman, is there a specific informed consent form required to provide telepsychology services? And can you speak to the issue of informed consent?
So Jared might be able to speak to the specifics of the form. I'd like to speak first to the question of informed consent. Many of our colleagues will look to get consent, and they want to have a form and a signature. And I see a lot of people get into sticky situations because they don't really have informed consent. And I think it's imperative for us to make sure that we speak to the client about the pros and cons. HIPAA may have relaxed its enforcement standards on video conferencing right now and the kinds of platforms we can use, but that doesn't mean that we don't have the obligation as the provider to still give our client some realistic information about the possibility that the platform we're using could be their information could be compromised because that platform has not signed a business associate agreement. I think that we need to make sure that we're giving that informed consent and that we're documenting that in some way, whether it's its own form, whether it's incorporated in a form that we have already in place or that we've newly revised, or sometimes we can't even get them to sign the form. We can mail it to them, but if we mail it to them and it takes a week to get it back, they may need our services before that 2 weeks. and we may have to document in the meantime. If they don't have a printer or there's no way they can electronically sign the form, we may have to document that we're sending them the forms and have done the informed consent, the informed part of that, and we're waiting for those to get back. I know a lot of people might have issue with what I just said about not having the signed form, but I really think two things are important. You need some type of documentation, and you need to make sure that it's truly informed consent, not just consent.
Yeah, I think that's right. I actually don't have any difficulties, Jeff, with what you just said at all. This is genuinely a crisis, and in a crisis, you have to change what you're doing in order to make sure you provide the best care that you can at the time. Now, I'm not an attorney and have no intention of giving legal advice, but just on a clinical level, if I were seeing folks, I wouldn't have any hesitance about doing what Jeff just suggested, which is I think providing verbal informed consent, documenting that you did it and the date and time that you did that, and then trying to get the papers signed, which is of course best practice as soon as you can do that. I think that is a reasonable accommodation during this time, my opinion. Again, we haven't reviewed that with the lawyers. Go ahead.
I would much rather have to answer the question of why didn't you have form ABC 123 signed as timely a way as you should before you provided the treatment. I'd much rather answer that question than the other question of why didn't you provide the treatment and now the patient is dead.
That's exactly right. I agree with that wholeheartedly. Even without the catastrophic outcome, that's right. I think our obligation, even the way the ethics code reads, it reads that you're supposed to do good in the world, and second is do no harm. I think we forget that do well or do well by people or do right by people actually comes first. So I think this is an example of that. I agree. Specifically, so if we want to get to technical details just very briefly, it is best practice. You are actually supposed to have a consent form to do telehealth services. We have an example of that on the APA website that was published in, again, our practice update, which you can, if you just Google APA practice update, you'll find that quite quickly. That's a nice example that was reviewed by the lawyers that you can just use. You can use that for free, copy parts of it, whatever you'd like to do. It's open for use.
Great. So as I've mentioned, we got a lot of questions from people who are trying very hard to get up to speed, may not necessarily be fluent with, different technologies and formats, Zoom or Skype or whatever technology they're trying to learn while providing services. Dr. Zimmerman, can you just go over some tips or suggestions on how best to offer an online session while retaining the benefits of effective communication and a strong therapeutic relationship?
Sure.
Yeah, sorry,
I think
Dr.
there are two main.
Edwina?
I think there are two main categories here of ways of thinking about this. One is technical and the other is behavioral. So as an example of some of the technical aspects, I would only have the video chat on your screen, not anything else in the background. I would turn off all notifications. I would move the image of the patient to the top of the screen so it's more closer to your camera, so you're having better eye contact or the appearance of better eye contact with the person on the other side of the screen. If your screen is especially on a laptop, a phone, or a tablet, I'd put it up higher on books so it's more at eye level rather than looking up at you from below. And I would also wear earphones. Earphones can help increase a sense of privacy when the patient sees that you're wearing earphones, and I would suggest that they do as well. At least what you're doing is you're muting the incoming discussion from anybody who might be able to overhear it in either of the two environments. So you're helping increase a sense of privacy by doing that. Behaviorally, I would suggest not multitasking during the session. We're often used to doing that once we're on our computer, but I wouldn't do it in a video session at all, Be aware of what's behind you on the camera. Be dressed professionally. Avoid having the session in a place such as your bedroom, even though you might be more comfortable there. And I would also suggest querying the client or the patient about what their experience is on the video chat or the video session, the telehealth session, and was it a medium that was okay for them? Would they prefer a phone call instead, and paying attention to what Dr. Skilling said? Do they have to reach out to you for that? You can have a time that they're going to reach out, but what's working better for them? Some clients absolutely might prefer the video, and others might prefer the phone. So I would look at those two areas, technical and behavioral. One other last quick thought about that is that on the technical side, be very familiar with the platforms you're using and how you can direct the client. Don't expect them to read a 20-page PDF about your platform. Be very familiar so you can direct them easily and quickly with 2 or 3 prompts, how to get logged in, what to do if they can't log in, how to unmute, how to get their video going, so that you're really proficient on that platform. And you can even have a second platform to use if nowadays, because of the traffic that I think, Jennifer, you were mentioning in the intro, if your platform goes down, and how to have a second platform that you're also proficient in.
Yeah, definitely. And then just a quick follow-up. We've also received a lot of questions, and I'm not sure if you'll be able to speak to this, Dr. Skillings, but we've gotten a lot of questions. What platform should I use? What platform is HIPAA compliant? Do you have any thoughts on that?
Yeah, we had an article that was that came out late last fall, where we had 5 independently licensed psychologists review 4 platforms. Actually, I don't have it in front of me. I think it's 3 platforms. They reviewed Zoom, Doxy, and Theralink. And they listed, it was sort of like just kind of like a review, their own perspective on how well it worked and the privacy issues and all that. So that's actually online. We can make sure folks have it. The other one that I've heard, in addition to those 3, which all got pretty good reviews, the other one that I've heard pretty commonly people using is called VC, and those are all HIPAA compliant platforms. We're still recommending, just so folks know, we're still recommending that as a best practice for folks to use HIPAA compliant platforms that have a BAA agreement or business associates agreement. The reason why is because technically you don't have to have one if the platform does not record any data at all about the patient or the interaction. The difficulty is it's hard to know these days whether they have any recording or whether it might be stored in some kind of temporary format, or what happens if somebody hacks it, if it's actually in a temporary format. So just as best practice overall, we recommend that you do use a HIPAA compliant platform, again, because state laws have not been waived or relaxed in some cases, even if the federal ones have. And really, this is ultimately about patient privacy. So we can debate the legal issues about what's the right thing to do or not. In this case, I would suggest the more conservative approach of using the HIPAA compliant stuff, because it's really about the patient's best interest.
Great. And then Dr. Skillings, lots of questions about this too, and I believe you touched on this, but I just reiterate, is there any way to speed up getting Medicare to approve phone sessions? Is it illegal for me to get, somebody on the line is not muted, sorry. Is there any way to speed up sorry, I'll start again. Is there any way to speed up getting Medicare to approve phone sessions? And is it illegal for me to continue doing pro bono phone sessions with seniors who need help with video conferencing?
Yeah, that's important. Let me address the legal piece first. So it is as long as you're licensed in the state and providing services as you would ordinarily, paying attention to state licensing laws, it's not only legal, it's actually ethical and reasonable in a lot of circumstances to do that. Many circumstances. I'm just disappointed we have had a hard time getting the phone therapy, phone-only sessions to be turned on as quickly as we have had other types of services. Um, I mentioned very briefly earlier, there is now a workaround that Medicare has put out that's only in Medicare, not necessarily in Medicaid or commercial payers. We're going to work on getting that fixed. Down the road, what we're really shooting for is we're really going to try to get it, to make it set up so that way when you see a patient, if you're doing a phone-only session, that's your best judgment with the patient's preferences, that's the type of therapy or treatment you want to do, that you would be able to do that very easily and just code it and have either a modifier or a change in the location that you're providing the service. So that way we work just like telehealth or video conferencing. So that's what we're really hoping for and advocating for across the board. But I want to be crystal clear, it is absolutely okay for you to provide phone-only sessions. It's your decision about whether or not that makes sense for you given the financial arrangements. But I do just want to say how much I appreciate out of the goodness of folks' hearts how many people are doing that right now. It's really heartening to see how many people are trying to do right by their communities that they serve.
Great. And one last question that came in the question box that I would like to ask before we're running out of time. What do we tell clients who are living alone and feeling isolated, not being able to have physical contact, aside from rarely going out and having to stay 6 feet away from each other? What advice do you have really about loneliness? Whoever wants to take it.
Jeff, you want to start?
Sure, I'll start. I think it's about connection. And while a person like that may physically be alone, I think it's a question of how much do they reach out to family members and friends, and do family members and friends reach out to them? We've actually had hors d'oeuvres with friends in the evening, which we never would do via video. We're about to see friends from another state this weekend this way. And it's about reach out to your adult children, reach out to grandchildren, have people reach out to you, set up a structure for some of that. We took our grandchild to the museum, quote unquote, so to speak, because the museum had a child-friendly site and we shared a screen. We had an hour and a half with her looking at paintings in the Metropolitan Museum, and at the same time, her mom got a rest for an hour and a half.
Yeah.
So if you're alone, it even becomes more important to have those connections, and you can calendar those in, and your clients can calendar them in if there are people that they can connect with. I'm also aware that there are a lot of agencies, especially some of the agencies that help seniors, that are actually reaching out to their seniors and calling them every day or every couple of days to say, hey, how are you? And to connect. There's such an importance about connecting and saying hi and offering some time, even if it's a short call. But with family and friends, it can be longer and it can be social, even though it may feel a little bit weird to be doing it this way.
Yeah, I agree with everything he just said. I would only add one additional piece, which is to be creative about how you're doing it. You don't have to just keep doing the same things you've always done. You can think of new ways to use the video, take it new places, take your computer out to your back deck or front porch, or take it with you on a walk in your neighborhood while staying 6 feet away from people, of course. Just on a personal note, we have started doing virtual happy hours every Wednesday from 4 to 5 p.m. with my staff in the APA practice office. We have a no business discussion rule during that hour, and everyone seems to really like it. People have pulled out photos from their high school yearbooks and everything that we would have never done this before. It's been great. But that's a really important thing to do, is make sure you maintain connection and have that meaning in your life with other people.
Great. Thank you very much. Unfortunately, we are running out, or we have run out of time. So that's all the time that we have for questions today. And on behalf of the Office of Continuing Education at the American Psychological Association, we thank you all for joining us today. And of course, we'd like to thank Dr. Zimmerman and Dr. Skillings for sharing their time and expertise with us. As a reminder, advance here. As a quick reminder, we will be offering the third and final installment in this webinar series, question and answer, next Friday, April 10th, and registration for this session will open on Monday. The link for last week's session is not yet up, I believe, but it will be up shortly. Watch for that on our website. We would like to direct you to some resources which APA is happy to make available related to telehealth and general pandemic resources. Links to these resources are listed here and can be found on the APA website at apa.org. So thank you again for joining us, and this concludes today's webinar.
So everybody's still there? Is this over, or did we cut off?
I
No,
don't
I'm
know
here.
who ends.
Okay, we're still here. Okay.
I'm here.